afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on prioritizing pathogens for genomics. My name is Sean Clark. I'm a clinical microbiologist at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, or if you require CME credits, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I am part of the working group that Dr. Isabel will be describing, but do not have any other conflicts of interest to disclose. It's now my pleasure to introduce the speaker for today's presentation, Dr. Sandra Isabel. Dr. Sandra Isabel is a medical microbiologist at Public Health Ontario and a pediatric infectious diseases specialist. Her research focuses on improving the prevention and diagnosis of infectious diseases through innovative technologies. At PHO, she leads a working group defining which pathogens will be prioritized for genome sequencing. I'd now like to pass it to Dr. Isabel to begin today's presentation.
Thank you, Sean, for this introduction. So I'm really glad to be here today to get the chance to talk to you about how at PHO we figured out how we would prioritize pathogens for genomics. And we've learned a lot, and we're hoping that you're going to be interested as much as we are in this topic. So first, I do not have any conflict of interest to declare. And there's three objectives that we will meet with this presentation today. So first, I'll describe how microbial genomics can impact decision-making in public health, mainly during outbreaks. Then we'll also explore the other impacts and benefits of using microbial genomics in public health practice. And finally, we'll explain the importance of prioritization exercise in public health organizations in general, but focus more specifically on how to do that for genomics. And now I'll talk to you about what we will learn during this presentation. So first, I'll define what genomics and genomic epidemiology is for the people that may not have been exposed to it as much. Then we'll talk about what's in the literature for genomics and how it can impact decision-making in our context. And how it can impact public health in general. Then we'll talk about what pathogens should we sequence based on the evidence to finalize on something more specific to that presentation, which is on prioritization. And we're going to review the example of the WHO resistant bacteria priority list. And then we're going to talk how can we adapt such a process for genomics specifically, and how we did that at PHO with our own genomic pathogen priority list. I want to let the audience know right now that we will not present the exact ranking as the validation is still in progress. We are actually closing the survey as of now. So first, before we start, what is a pathogen genomics? So we can decrypt the nucleic acid codes of the pathogens to produce sequences. So these may be ATCG, TCAG, so like very significant amount of data with codes of the nucleic acid sequence. We have, like, for about 20 years now, new technologies that are called next generation sequencing. And they're great because they allow high sequencing capacity and high resolution also. When we analyze all that amount of data. Genomic epidemiology is also a concept that is really important to understand this presentation. So microbes evolve by the acquisition of new mutation or by other phenomena that I'm not going to all detail here. These changes in the genome can be identified by sequencing. So if, for example, we have like a first bacteria number 1, so the great grandparent here, this is what we call the sequence wild type. And then there's going to be a next generation, so the grandparent in that case, that can acquire a mutation that is going to be called here, like we see in red. So there was like a nucleic acid that changed from an A to a T in that generation. And then we're moving on to the next generation. So the parent that acquires the mutation from the grandparent, the T, but then there's going to be a new mutation that arises in that generation. And these two mutations will be passed on to the child, so the generation 4. So following that and doing that analysis and the comparison from the sequences can help us understand how the disease, infectious disease, are spread in the community. And this can be done at outbreak level, but also like at broader level of surveillance in between countries, for example. So as of now, microbiology lab have incorporated or are incorporating pathogen genomics. One example is PulseNet for foodborne pathogens. So you will have heard, for example, like on the news, that salmonella may have been identified in a specific food from a specific producer, and that there may have been a recall because of that investigation. You also, I'm sure, have heard on the news about SARS-CoV-2 and how sequencing happened, and this allows us to identify new mutation and at times new variants and track how they're spread from one country to another. So how does pathogen genomics do influence decision-making in public health is really important. How does it impact public health also? We are going to look also at what's the cost effectiveness of this and what's in the literature for that. The next question is what pathogens have been selected for genomics by other public health organizations and why. So to answer all these questions, we did a scoping review at PHO. So what we did is this search of this Venn diagram where we wanted to find papers that were discussing these 3 topics. So they had to talk about genomics and pathogens, infectious disease, or public health. And they had to present a list of pathogens for genomics, decision-making, or like an impact assessment or cost-benefit analysis in the context of public health or infection control. So with that search in the index and GRI literature with the help of our librarian in 2 different languages, we were able to screen 990 abstracts and 212. We read fully 212 papers, and of those, like 114 answer pieces of these questions at this intersection in the Venn diagram. And because the literature is not even for pathogens, so for example, pathogens some have been more studied, we added 83 other papers to that for pathogens that had been less studied. So to answer one of our first questions, what other organizations are sequencing? I'm going to provide the example from the government of Australia. So in their national microbial genomics framework, they give a list of pathogens that they've included for sequencing. So these include resistant organisms such as carbapenemase producing Enterobacteriaceae, Candida auris. They have also foodborne pathogens right here, similar to PulseNet. And they have also like other diseases of public health significance, such as diphtheria, Legionella, TB, and Neisseria meningitidis that can cause meningitis. And it's very interesting when we compare different organizations to see that the lists have similarities, but can be different. And some of those organizations will explain the reasoning for each pathogen, some will not. So it was difficult to track down like all the rationales before that when we compared it all together. So before we talk about our own prioritization exercise, I want to provide some cases from the literature to make you understand how genomics can indeed impact public health. So I've selected just a few papers with the time we have today to give you examples that we can review. So there's this paper from the UK by Joshua Quick, where there was an increase in the number of cases of salmonellosis that was found in a microbiology laboratory. So in their lab, they noticed there were more than 30 cases in 3 hospital sites and in the community over a 3 weeks period, while the typical was much less. So we're talking about 5 to 8 per month in their typical like baseline. So based with that, there were questions about the fact that there could be a salmonella outbreak in their healthcare institution, or could it be only like multiple importations from the community? So to respond to that difficult question, they decided to do rapid sequencing in their hospital laboratory. And then with that and with environmental screening, they were able to find the source being the food distribution and contamination of the food trolley and staff involved in the distribution. They were also able to rule out the relationship with the concomitant child care cases, which was also helpful as an information for the investigator. And all of this information led to more precise interventions for infection control, in this case, food distribution. For the people who might want to have like more results, like it's a good paper to read, and it may give you other examples if it's something that is in your practice. Another paper, which is different, I wanted to talk about, it's about hepatitis A. So in 2016, 2018, there's an outbreak of hepatitis A in men having sex with men in Europe. And in that context, there was a vaccine shortage in many countries, which led to different decisions making in different countries, either to limit the dose or the antigen dose for the vaccination program. And what happened in Barcelona is that they had cases of hepatitis A in vaccinated individuals. So in that context, what they did is that they had access of the 159 cases in Barcelona, they had access to a few number of cases. And of those, they were able to sequence 5 cases that were vaccinated for hepatitis A and 8 that were not vaccinated. And in that context, it's important to mention that of those 5 vaccinated, some were fully vaccinated with full doses and two doses. So here what they've done is that they've done sequencing, and what they've realized is that there was a higher diversity in the epitope coding regions for the vaccinated case compared to the not vaccinated case. It's important to mention that in this case, they had very low number of samples to draw any strong conclusions with that. It would have been interesting to see more samples being sequenced or that being confirmed from other countries, for example. But it still led to a rethinking and to recommendations on vaccination to avoid escape variants. So again, if it's something that is in your practice, I recommend reading the full paper on that topic, as it is quite important. Finally, the last paper I'm going to present in that case is one about an economic analysis. So in the UK, which is a low burden setting for tuberculosis, there was modeling of cost effectiveness of TB, PCR, and whole genome sequencing. And in this case, they estimated that there could be an incremental net benefit for TB with that strategy of like $14 to $16 million over a 10-year period. So that's something that was very interesting. There are many other papers in the literature that talk about cost benefit for genomics, and particularly on tuberculosis and salmonella. Those are the ones that have been most studied in that context, but they're starting to have more literature on resistant bacteria and nosocomial healthcare-associated infection and transmission that are also very interesting. So again, if that's something that is of interest to you, I would recommend for you to read more on the topic. So in summary, our scoping review findings is that we found that there is evidence that pathogen genomics can indeed influence decision-making in public health and impact public health, and it also can be cost-effective. The level of evidence differs for different pathogens. So again, there's more literature for some, such as Salmonella, Listeria, TB, and the Enterobacterialis with a lot of resistance. And there is very little or no literature on many pathogens that are still important. It's just that there is very little literature on those. So we had to dig deeper for those ones and add in an extra layer of papers to help us with that data gathering. And it still brings us to what pathogens should be sequenced. So as I mentioned earlier, the list of pathogens sequenced by different public health organizations differ. And there's no like pathogen ranking for genomics in the literature at the moment in that context. So what we did then is that at PHO, we decided to put more attention to it to help us focus our resources. And we looked at other prioritization efforts. And then I learned that it is no small task. Prioritization efforts for public health is quite complex. And it is really important as it allows to put resources where there is like more potential benefits. And some example of that you may be more familiar with would be lists of reportable disease by different organizations. And in that context, the one we looked into a bit more was the one from the WHO that lists and ranks bacteria with resistance. And we're going to tell you more about that study and then how it inspired us. There's multiple methodologies that can be used for prioritization exercise. One of them is multi-criteria decision analysis, where you set like some different criteria, and then that allows you to rank pathogens or other things. But so that's what we went with. So we are going to talk first about the WHO, what they've done, and then we'll dig into what we have done at PHO. So the World Health Organization had said that antibiotic resistance was a high priority because of the increase in the incidence globally. So in their guidelines that they call prioritization of pathogens to guide discovery, research, and development of new antibiotics for drug-resistant bacterial infections, including tuberculosis, they went through that process and they explain it very nicely. So if people are interested, again, I would recommend to go and have a look at this document. Very important here to note that this particular prioritization exercise was really for more for development research in that case. So what was done is that they selected 9 criteria. Okay, so they selected mortality, healthcare burden, community burden, transmissibility, prevalence, 10-year trend of resistance, preventability in community and healthcare setting, and treatability and pipeline. So here I can show that, sorry, I'll have to go back one second. So here what they've done is that they define each criteria, and then for each criteria, they put level. So for example, for transmissibility, this is something that has low, moderate, or high transmissibility. And what is the definition for each criteria level? And by doing that, they still had to see what criteria might be more important than one. So for example, one may think that mortality is more important than the pipeline, or treatability might be more important than the pipeline, the research pipeline, for example. And how do we do to figure out like what's the weight for each criteria, and beyond that for each criteria level? So there's different strategies that can be used in the literature. The one that they've decided to use requires experts. So they had experts that they surveyed, and they use what we call the paprika method. So the paprika method is called like potential all pairwise ranking for all possible alternatives. And it allows for an expert to decide which combination of criteria level would be most important. So for example, for you, is it more important if it's a lower mortality but a higher transmissibility versus a higher mortality and a lower transmissibility? Or is it the same for you? So I'll let you think about that question briefly, and then what softwares can do to sort out, again, like the prioritization and what criteria might be more important than other criteria, is that they will make different sets of combinations of that, and then they will be presented. So they may have, the stakeholders may have 40, 50 combinations like this, in which they have to decide which one is more important. And by doing that, we are able to figure out the weight for each criteria level. So for example, here in their work, the treatability, so the light blue line at the top, was the most important one, okay? So in that case, treatability was more than 14% of importance at the top criteria level. And you can see that that same line was not straight. So that importance of the criteria level is non-linear. And by doing that strategy with the paprika method and the stakeholders, they were allowed to do that. And this allowed for the WHO to rank the pathogens in order of importance. So you can see, for example, here they had Acinetobacter baumannii at the top, and then Pseudomonas aeruginosa, E. coli, Klebsiella. And you can see that in the critical priority that they've set, they have chosen Acinetobacter Pseudomonas and Enterobacteriaceae. And so really that ranking and the advice from experts allowed them to do that. You can also see with the statistics that all the respondents are not necessarily going to rank each criteria and each criteria level the same. So because of that, it is important to make the statistics and compare. So you could see that, for example, Enterobacter and Escherichia coli here are very similar in the results, and their statistical variation has like a good overlap. So with that knowledge and reviewing, again, the other prioritization efforts from different organizations, we moved on to what's really the most important part of our presentation. It's how can we prioritize pathogens for genomics here at PHO. I want to mention very clearly here that this did not address diagnostic based on whole genome sequencing. This would be for another topic. It really addressed how like genomics can be used for outbreak investigation and surveillance. So this was done here with a working group and at PHO. And here I want to present the algorithm that we designed to be able to do that. So first of all, we reviewed all the diseases that were reportable in Ontario. And then we added to that other nosocomial pathogens, so pathogens that can cause healthcare-acquired infection. And then we put them all together. So we had a list of more than 100 pathogen group here. Before I move on, I just want to define what a pathogen group is. So for example, Salmonella, there may be different serotypes and different species. So the Salmonella species as a group would be a pathogen group that we put together. So with doing that in that list of 100 pathogen groups in that context, we needed to remove some because it was a lot of work. So what we've done is that we created exclusion filters, and these included, for example, technical reason. So one example would be that if at PHO, the type of samples we generally received would not include enough nucleic acids from the pathogens to be able to perform the whole genome sequencing, that would be a reason for exclusion. Then the reportable disease list includes syndromes. So for example, we're talking about encephalitis. So encephalitis can have multiple pathogens that can cause that disease. So we couldn't include all those pathogens, even if the syndrome was included in reportable disease. We did, though, include some that were key and were, like by themselves, reportable disease, including Streptococcus pneumoniae, Neisseria meningitis, and also Haemophilus influenzae, for example. Then we looked at our incidence in Ontario, so things that had such small number of cases in the province, then we had an exclusion filter for those. It is important that all those inclusion filters were overseen by our working group, and these experts' opinions sometimes made us like put back in our analysis group some pathogens. So one good example would be polio, and similar, where if we had no cases in the province, we still could put it back in because of its importance globally. So then that made our pathogen list for prioritization. So we had 54 pathogen groups in that list. And then we started the work on doing the multi-criteria scoring and getting expert opinions for that. And this is where we're still like in validation for this, is building those high priority pathogen group, moderate priority, and low priority pathogen group. I want to show you very briefly the 54 pathogens group that we chose. So you can see in the reportable disease list, we have bloodborne infections, enteric disease, and foodborne diseases that were selected. We also have respiratory diseases, sexually transmitted infections, and vaccine preventable disease, and finally, vector-borne and zoonotic disease. For our continued list, now we have healthcare-associated infections that may not necessarily be reportable. So we added those based on the CDC list and the WHO list. And it's important to mention that there are healthcare-associated like infection pathogens that are already reportable. So we're already included at the top. So with these 54 pathogens, we still now had to figure out how to prioritize the most important one and based on what. So we designed criteria for this. And this took a long time to sort out because we couldn't find in the literature any other publication on that. So people may have defined epidemiological criteria like here, for example, so it was not too complicated to modify, but still we had to put lots of attention to it to make sure we are capturing the most important information that was available. And then we had to design criteria for genomics. So the first three criteria are epidemiological. So we looked into transmissibility, potential for outbreak, and incidence in Ontario. And then with that, we put some criteria levels to all of those. And with evidence and expert advice for each 54 pathogen or pathogen group, we added the criteria level that was the most representative for this pathogen. Then what we've done is that we moved on to make the design for the criteria for genomics. And as I said, we didn't have like much other examples to go with. So we went through different iterations to make those criteria. So the first one that we put together is whole genome sequencing power to understand transmission. And then from this, we were moving on from the literature has no evidence that it can rule out or rule in transmission, which can happen for some pathogens. Some of it just because the studies haven't been done yet. We didn't find it in our review. And then can rule out transmission, can enable cluster analysis, can infer relatedness and transmission, and then can identify unrecognized transmission and outbreak. So those were the criteria level. Then the next one was impact of whole genome sequencing on public health and infection control. No evidence that whole genome sequencing influenced decisions was our lowest ranking criteria. And that happened for many pathogens on that list. Whole genome sequencing can lead to more precise investigations where it's the investigation resources can be focused on the outbreak based on that. And the last one was whole genome sequencing can lead to more precise interventions where it changed something that we were doing based on the analysis that was done with the epidemiological and the genomic data put together. Then the last criteria was about cost effectiveness. And the first one is that there's no evidence of cost saving for this pathogen. So a lot of pathogens also were in that criteria at this point with the data we have in the literature. There is proof of cost effectiveness in the laboratory for some of them. There's cost effectiveness for investigation where, it helps figure out the outbreaks more easily, and the resources can be used better, and it can be cost effective in that consideration. And the last level is that it's cost effective at the population level. And there were, for example, some good studies on that level for tuberculosis and salmonella, but also other pathogens. So based on those criteria level, we gathered the information on the 54 pathogens, and we've reviewed about 200 papers that we've included to that, and we determined the level for each pathogen or pathogen group. I can't present the 54 to you at the moment because that would take way too long. However, the data will at some point be fully available for everyone to see. But you can see that, for example, of Mycobacterium tuberculosis is right here, and with the 6 criteria, it was ranked as transmissibility is high, potential for outbreak is moderate, incidence in Ontario is moderate to high. Whole genome sequencing power to understand transmission. Here we said that it can identify unrecognized transmission or outbreak, which is not surprising with the very long incubation period that tuberculosis can have. It has an impact of whole genome sequencing on public health and or infection control. So it can lead to more precise interventions. And the whole genome sequencing cost effectiveness, we saw that it was cost effective at the population level in different studies. So with that, we had to gather the ranking and the weight. So as for the WHO, we use that paprika method on the platform called 1000 Minds. And so what we asked our stakeholders was the following. For the use of whole genome sequencing in infectious disease surveillance and outbreak investigation in the public health and infection control context, which of these 2 unnamed pathogens should be prioritized? So in that context, would you say whole genome sequencing power to understand transmission? There's no evidence that it can rule out or in, and it's high, though that pathogen is highly transmissible. Or you have pathogen B here, where whole genome sequencing power to understand transmission, which says that it can infer direction of transmission, the transmission is low. So which one would you select, or are they equal to you? So what we've done is that we surveyed stakeholders, and again, I just want to say that we're extremely grateful for the people that have answered the survey. We send it out to many people at the provincial and national level also, and we have like PHO colleagues that also answered. This one was launched on September, at the end of September, and we're closing it as of today. So we've had with that more than 70 stakeholders that completed the survey with different backgrounds. So some were genomics specialists, clinical or medical microbiologist, data analyst, epidemiologist, and infectious disease specialist, public health physician or investigators, for example. So what we found is that the PHO genomic pathogen priority list we were able to, with our stakeholders, to put together the criteria order. So very interestingly, like 54% of the weight was put on the 3 criteria related to genomics that we see right here. So cost effectiveness, power to understand transmission, and infection control. And then 46 of the rest was on the epidemiological factors, so 54 and 46. Interestingly, the WGS power to understand transmission was at the top, which does make sense, and I thought was interesting to find. And the second criterion, whole genome sequencing, was right here. And last, we had whole genome sequencing cost effectiveness. So there is indeed not that much literature yet on that topic. Those are hard study to do. They're very worth it, but they're hard to do, so they're not done very commonly. So it was good to see that although it's deemed important, it's not as important as the other criteria. So next, we were able for each criteria level to put like a certain weight on those. So you can see, for example, the blue, the darker blue, WGS power to understand transmission, that is the highest of the 6 criteria. So what we're going to talk, I'm going to talk now, is our primary results. Unfortunately, as we're closing the survey now, we haven't finished validating all the results. Although our first layer of statistical analysis does show good support. So the Kendall W trends agreement between survey respondent, the highest is the better and the maximum is 1. So we have 0.9 here. Similarly, we had like a high Spearman rank correlation at 0.9. And what we are going to add like layer of statistical validation. So what we want to do is we had different groups of respondents with different expertise. So we want to compare how their responses were, and that's going to be helpful to assess the robustness of our method. I can give you as an information example of top ranking that we had, for example, Enterobacterialis and Acinetobacters that were ranked high in that exercise, considering their importance with healthcare-associated infection. We also had, no surprise here, Salmonella that ranked high, tuberculosis that ranked high, TB, and SARS-CoV-2. So we have very good examples of whole genome sequencing that here. So some of those pathogens are already being sequenced as part of different programs. So it's good. It's really good to see that the one that we were expecting to be high because of the strength of the evidence in the literature did go up in our ranking. So what we have to do to finalize the ranking at this point is that we have to have like an expert opinions and the final statistical analysis, and we'll do those 3 groups: high priority pathogen, moderate priority, and low priority pathogen group. So in summary, we have microbial genomics here shown that we can impact public health investigation and interventions. The examples were Salmonella and hepatitis A at the beginning. Prioritization exercise for public health is complex and important, and we presented the approach here that we chose at Public Health Ontario for a genomic pathogen priority list. We use that approach because it's unbiased toward pathogens, so respondents that may have more expertise or more interest toward one pathogens couldn't choose these pathogens based on that expertise or interest. So we still have at the moment statistical and expert validation in progress. We will rank the pathogens in 3 categories: high, moderate, and low, and this information will be made available. And we're hoping that this will help to focus our whole genome sequencing resources on pathogens with the highest potential benefits. And last point here, the adaptability of the method is really important, because by ranking the criteria and not the pathogens, if the literature changes for the criteria, or if the incidence of those pathogens, or if there's new pathogens that arise, then we can adapt that ranking efficiently, and we can reassess it periodically. So to finish, I'd like to thank all the stakeholders that completed this survey. We're extremely grateful. Thank you for your time and your interest. And the PHO working group, of course, some of our collaborators at NML, and some of our colleagues that reviewed the scoping review, including many of the residents in different programs in Ontario. And finally, thank you, Jessica Hopkins and Samir Patel, for your guidance in this. So thank you for listening, and I'll be listening for more questions.
Thank you, Sandra. We will now move to the Q&A segment of this event to address some of the questions from our audience. Just a quick note to everyone, please continue to enter your questions into the Q&A pod if you have not already had an opportunity to do so. I know there are a couple questions in the chat pod already, but I'll kick things off and allow people some time to think of some of their questions. So the first question, I guess that, first of all, this was a fantastic presentation, Sandra, on an important topic. And you mentioned that you selected 6 criteria to work with as part of the prioritization exercise. Were there others that you had considered or have considered that were not included as part of your analysis? And if so, are there any that you may, think that others might want to consider in their prioritization exercises?
Yeah, thank you, Sean. This is a very important question. We did consider many other criteria. I have a couple of examples I can give. So for example, we wanted to assess severity of disease. There's different ways of doing that, and gathering the data for 54 pathogens in our Ontario context was not, it would have been difficult to be consistent with the different, all these 54 pathogens as they may not be studied the same way. So we decided not to, in this iteration of the process for that part. The WHO had used that information though in their own in their own context, which didn't make sense though, because it was more about treatment development and other research and development. The other thing also, we had considered the turnaround time, because we know some pathogens will take more time than others. And another thing was the ease of lab implementation we had considered. When we did the trial run survey, we realized that it was quite long to answer the survey with all these criteria, and that many of the first people that answered in our own group didn't weigh them very high. So we decided to remove them in that context. They are still important. It's just that they were at a significantly smaller percentage compared to the others. And one of the important thing about multi-criteria decision analysis is to find the soft spot where you have the lowest number of criteria that allow you to do your prioritization work properly. So I think that once we received the results, we were confident that the selection we had done for these 6 criteria was good.
Great, thank you. I'll just follow up with one other question, and then we'll start going to the Q&A pod. So one of the important themes that you've mentioned throughout your presentation is that, there's a number of collaborative groups, experts involved in part of this process. What do you think are some of the benefits of having these groups and the importance of these partnerships when doing these types of exercises, particularly in the setting of prioritizing pathogens for genomics?
Yeah, absolutely. So our working group, like at Public Health Ontario, included people with much different expertise. We had like a pathogen genomics expert, data analysts, public health physician, epidemiologist, microbiologist, infection control and prevention specialist. So from the start, the working group composition was really transdisciplinary, which really helped us make it more robust. And then there were some, steps in the process that were harder. And then we got the chance of validating with external partner. And I'm really thankful for some of the collaborators at NMLs that helped us with the definition of our criteria. So it's always useful to have like an outside opinion also from other experts.
That's great, thank you. So we'll move to our first question in the chat pod. Can you describe the practice gap that this project will help address? In other words, what problem will this solve? For example, are there some pathogen groups that are not currently undergoing WGS or have significant delays that will now be prioritized?
Yeah, I really like that question because this is exactly the reason why we did that work. And in genomics, people may have developed pipelines and may have developed an expertise on one pathogen, for example, but it doesn't mean that it's a pathogen that would have bring the most benefit if it were sequenced. So we were in a step that, SARS-CoV-2 sequencing and PulseNet sequencing was done here at Public Health Ontario and in many other organizations, and we had to decide for the others. So instead of just picking randomly, that's when we decide to go through that prioritization process to decide what else would be validated and added in our list of pathogens being sequenced.
Right. Next question centers on numbers. So have you considered what fraction of cases to sequence for each pathogen?
Yeah, this is a very good question. It's beyond this prioritization process. WHO has some guidelines for certain pathogens on that topic that can be read and help. But again, it is something that needs to be adapted depending on what's the context. So is it at a surveillance level versus is it at an outbreak investigation level? So then we need to adapt the proportion of the cases that will be sequenced. So I don't have a specific answer for that, but I would suggest to go in different documents that do discuss this context, and this has mainly been learned with SARS-CoV-2.
I'll just ask another question, just because I see we have a couple questions left. With respect to the scoping review, you mentioned one of the challenges, again, sort of going back to numbers, is that the literature is not even. You mentioned that you had to, add in 83 articles for some pathogens that have been less studied. What are some examples of pathogens that are less studied and may fall in this category?
So we had pathogens that were more rare. So for example, Coxiella burnetii, that causes Q fever, or Brucella. Those are just more lower burden pathogens in our setting, and in higher income countries. So there were less genomic data or genomic studies that were done to prove what could be the impacts of genomics for those. So really the the burden, depending on where the people are doing the sequencing for different pathogens, does change like how often it is sequenced. So yeah, but otherwise it's the one that are already part of some programs and organization, of course, then they're studied better with like very different levels of evidence for them.
Thank you, Cedra. Our next question from the Q&A pod. I'm wondering how you would use the finding of no data. For example, there has been no research on genomics for a certain organism, as opposed to no evidence or evidence of no value when assessing an organism for priority.
Yeah, this is a very good feedback. Unfortunately, we had to use what we have in the literature at the moment. And I think that although this is considered a limitation of our approach at the moment, we need to think that at the same time we pointed to gaps in our knowledge for certain pathogens that could be answered in future. So I think that it's really important to like do some reverse engineering in that case and look, you know, for the pathogens for which we indeed didn't have that much data, like can we put some extra efforts to look into those too on a research perspective at first to see if there would be any benefit. So in the future, potentially there could be benefits to integrating them.
Our next question from the Q&A pod relates back to the criteria as part of your prioritization exercise. Did you consider financial costs related to analyses, and were those included as part of your criteria for consideration?
It's a very good question. We didn't consider financial cost per se. We considered the cost effectiveness analysis that were published in the literature. But again, those cost effectiveness, it can change from one from one place to the other, right? So if a program can be more costly in a location and less costly in another location, and depending on the incidence, it can affect indeed the cost effectiveness. So what we went for was the best cost effectiveness literature we could find in the literature. But again, that's another area of gaps, and I do hope that more health economists can help with that in the future to address more and more of these questions, mainly for the pathogens where there's no data.
Thank you. Our next question in the Q&A pod, what about collaborations with experts in veterinary medicine, especially in the context of the One Health paradigm, where it's been shown to be important to implement sequencing in these areas?
Yeah, I really like that question. That iteration of the process was more focused on human disease. I understand that One Health context is important. We do have a microbiologist at Public Health Ontario who has good expertise in veterinary medicine, and she was aware of the project, and in discussion we did have different feedbacks in many of these discussions. But I agree that it might be worth adding some other considerations and other programs for that context.
The next question in the Q&A pod, some infections are multi-strain, especially those that develop slowly and evolve to develop drug resistance, for example, tuberculosis. What are your plans to investigate diversity to make treatment decisions, as current practice is to sequence an individual colony of bacteria? And how might multi-strain infections be considered in prioritization exercises?
Yeah, this is also a great question. It's beyond what we have analyzed because this is extremely complex. So you mentioned tuberculosis, which indeed can have a good biodiversity even in one host. So this will be important to take into consideration. The diagnostic for that specific project, diagnostic was not part of our analysis, and we analyzed the part of how like tuberculosis contributes, of how genomics, sequencing of TB contributes to outbreak surveillance and investigation, but not diagnostic per se. So that would be like another question for another round indeed. But, you know, tuberculosis is an important disease, and there's different diagnostic strategies that can be used for that. And the whole genome sequencing is used in different countries to support susceptibility testing indeed.
All right, we have time for one last question. From the Q&A pod, would there be any consideration for including morbidity and mortality to prioritize your top 3 to 5 pathogens based on your initial 6 criteria? Ultimately, should the goal of implementing WGS at the public health level for a pathogen to improve the health of Ontarians, prioritizing those pathogens that have the greatest morbidity and mortality?
Yeah, this is a very good thinking. We couldn't do it for the 54 pathogens, but for a lesser number of pathogens, that is something that is a very good point. As I said, we're still like in the validation process of our data for the final ranking. So we will assess different possibilities when we're doing that. Thank you for bringing it up.
All right, thank you, Sandra. As we wrap up today's PHO rounds, I would like to thank Dr. Sandra Isabel for presenting. I would also like to thank everyone who has joined us for today's webinar. You can expect to receive a brief and anonymous PHO rounds survey for today's session. Please try and complete this to help us improve our programming. A reminder to everyone to save the date. Topic: the Ontario Public Health Convention will be held on March 26th and April 3rd in 2024 and is accepting abstract submissions for the program. Please check out topic.ca, tophc.ca for details. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.